Hello, everyone. I'm just going to give us some time for some other people to join us, and we'll get started right on time. Hey, everyone. Thank you for joining me. We're just going to let a few more people in. We'll get started close to right on time. Hey, guys, we're just going to let a few more people join us, and then we will get started right on time. Hey, you guys. I'm just going to let a few more people enter and then we will get started shortly. Looking forward to meeting with you guys for the next hour. Okay, hello everyone. I'm Dr. Rachel Haverland with Endometriosis Center of Excellence. We are going to get started. As a few more people enter, we will allow them to come into our chat. But this should be very much of an interactive experience. When you have questions, please put them in on the chat. Throughout the next hour, I'll go to the chat and answer some questions for you. I'm here talking about endometriosis. I get a little long-winded sometimes as I'm, excited to talk about this disease and some of the sequelae. But I also want to make sure that this is interactive and very much of a personalized experience. So when you have questions, please just put them into the chat. I'm looking forward to talking with you guys and hopefully educating a little bit more about, endometriosis. And specifically today, we're talking about the hidden twin of endometriosis. So what doctors miss about adenomyosis. And I think adenomyosis is very important to talk about. And, a lot of providers and even patients understand what endometriosis is, but sometimes we don't understand adenomyosis. And it is very common to have them concomitantly. And so today we're going to talk about the hidden twin, what doctors miss about adenomyosis. So, Texas women, let me tell you the truth that nobody tells you. You got cut open, you followed every rule, you waited, you trusted, you hoped, and somehow you're still in pain. You're still bloated, you're still exhausted, you're still hurting in ways that you can't explain. And this isn't just healing, and you shouldn't just give it time. That this isn't your fault. You were never told the full story about what's actually happening inside your body. And today that changes. I hope that, by the end of this session, you'll understand exactly why your pain didn't disappear, what your doctor likely missed, and what you can do this week to get your recovery back on track. So there's kind of this big lie that surgery fixes everything. Surgery is, here's the truth. Surgery removes what they can see, but not the underlying inflammation, the bloating, the exhaustion. Sometimes that stabbing pain doesn't resolve. Surgery doesn't fix the system behind the symptoms. And when you're still hurting months later after surgery, you start blaming yourself. Maybe you didn't rest enough. Maybe this is normal. Maybe you're just stuck like this. You're not. You were never given the full roadmap to recovery because most providers don't explain the second condition that can keep you in pain. Now, when talking about this, surgery is certainly important, but I think it's imperative to go over this, all of the different etiologies that can cause pelvic pain, that can cause the symptoms you're experiencing. So I'm Dr. Rachel Haverland. I'm a board certified gynecologic surgeon and an endometriosis specialist. I've helped now thousands of women in Texas recover after surgery, not just physically, but emotionally, especially when the medical system shrugged and said, you're fine. This webinar is not about blaming doctors or other providers. It's about giving you the truth in plain English so that you finally understand what's happening to your body and how to take back control. So we're going to talk about a few things, related to endometriosis and ultimately talk about surgery because surgery is important, but it is also imperative to add some of these other treatment plans to your overall multidisciplinary approach because that's when you're going to get the best outcome. So the first thing I want to talk about, surgery is not the finish line. Millions of women believe that surgery resolves the problem, but surgery is just phase one. Adenomyosis is the hidden twin of endometriosis. It lives inside the muscle wall of the uterus and it doesn't always show up on scans. Sometimes it's missed. It can cause similar pain, fatigue, bloating, and inflammation even after surgery. So adenomyosis is when the lining of the uterus grows into the muscle wall. The muscle of the uterus becomes heavy, it becomes boggy because these cells continue to secrete fluid, similar to how the endometrial lining does. However, they're stuck inside the muscle, and so there's nowhere for it to go. The uterus becomes very heavy, very soft, kind of sponge-like. When you see it at time of surgery, you notice that the uterus should be hard, like the back of your hand. However, a uterus with adenomyosis is very soft. If I push in with my instruments, it takes a while to come out. It's edematous, almost like your ankle after you were in a long car ride, for example. The tissues become kind of fluid filled, and that's why they appear to act like sponges. Other ways to identify adenomyosis is if the coloring of the uterus is not perfectly smooth. So the coloration of the uterus should be kind of like a pink color, but it should be uniform. Uteruses that have more adenomyosis or splotchy. We call that mottled in appearance. So some areas are a little bit lighter, some areas are a little bit darker. And even if you look at the edge and the surface of the uterus, usually it's not perfectly smooth. There's kind of like indentations or little areas that look like blebs or almost bubbles kind of protruding from the uterus, showing you that that tissue is somewhat filled with fluid. And that's consistent with adenomyosis. Adenomyosis can also show enlarged uteruses. So women, especially without pregnancy or without fibroids, if your uterus is enlarged, it's likely related to adenomyosis if you're noticing it. Fibroids can certainly cause enlargement of the uterus. You can have both fibroids and adenomyosis. We see that relatively frequently, but especially today, we're talking about endometriosis and adenomyosis in their connection, and how adenomyosis is this evil twin that frequently is not talked about. We talk about endometriosis, and I think as a society, we're learning more about endometriosis, but I also think that it is imperative to discuss adenomyosis and how adenomyosis can affect symptoms very similar to endometriosis. So I had a patient a few weeks ago. She had surgery with another provider. She followed every rule. She rested, she medicated, she walked, she waited, and still she couldn't make it through her day when she's on her cycle. Her surgeon kind of told her this is normal, but it's not. She had adenomyosis that wasn't diagnosed. So she came in to my office and we reviewed her surgical photos. We looked at the pictures that you can see, and in this instance, you actually could see the adenomyosis, and she hadn't, nobody had mentioned this to her. Nobody had discussed that adenomyosis can also contribute to some of the symptoms she's having. And adenomyosis specifically is inflammation of the uterus itself. So endometriosis gives symptom or is implanted tissue outside of the uterus. So we think that these cells don't migrate even when you're formed, like in utero, these cells don't migrate where they're supposed to be. They implant outside of the uterus. And so when they implant outside of the uterus, they start to grow once you get to maturity, once your body starts making estrogen. That's when these cells start to grow. And so the definition of endometriosis is these are outside of the uterus. They are not inside the uterus where theoretically they should be. And so when you get to maturity, your body starts making estrogen. That's when these endometriosis cells start to grow. And some people have immediate symptoms, right, when they reach maturity and start having their cycles. Other women, don't start showing symptoms until later in life. Maybe the endometriosis has grown to the point where it's affecting their nerves. Or some people aren't really symptomatic. Maybe they just have side effects, like they have trouble getting pregnant or they have chronic constipation. But these are all very common symptoms of endometriosis. But endometriosis is defined as tissue outside of the uterus, whereas adenomyosis is very much the uterus itself. This is inflammation of the uterus, uterine inflammation. Classic symptoms of adenomyosis are also very important to review. When I talk to a patient, I'm acutely aware of what they're telling me. When are they having their symptoms? When are their symptoms exacerbated? And it is sometimes hard to tease out which symptoms are related to adenomyosis and which symptoms are related to endometriosis, because very much these symptoms can overlap. And so kind of teasing these out to try to get our best idea of what's going on. Endometriosis can cause pain really at any point in your cycle. It causes nerve pain. It can contribute to chronic constipation. It can affect your bladder. It can cause pain with intercourse. It certainly can affect fertility. Endometriosis is the most common cause of unexplained infertility because of the inflammation that it causes in the pelvis, decreases your egg quality, increases the inflammation, makes it harder for the egg and the sperm to fertilize in the tube, and then also can affect early implantation. However, adenomyosis is very much a disease of pain during your cycle. It does not cause pain typically outside of your cycle, sometimes a few days before, but usually it's pain during your cycle. It causes heavy bleeding. Endometriosis, while it causes a ton of pain, does not necessarily affect the amount of bleeding that you're having. That's likely related to adenomyosis. Adenomyosis causes bloating during your cycle, which endometriosis also can, but frequently it is a combination. It causes pain that radiates to your back and down your legs. That is kind of classic adenomyosis. And some women feel like pressure, like a bowling ball in their pelvis. They start to feel heavy, heavy symptoms, and that's also consistent with adenomyosis. And a lot of these symptoms also sound similar to endometriosis. So you really have to kind of tease out which symptoms may be related to endometriosis, which symptoms may be related to adenomyosis, and then also understanding that a lot of times they overlap. And so having a high suspicion, one of the things that I look for is this heavy bleeding, because like I mentioned, endometriosis causes pain, causes inflammation, affects the nerves, but it doesn't necessarily affect the amount of bleeding that you're having. If you're soaking pads, passing clots, it's important to make sure you're evaluating the uterus for other etiologies that could cause these heavy bleeding, whether it's a polyp or fibroid inside of the uterus, whether it's adenomyosis, whether it's your hormone fluctuations, like you're not having regular cycles every month. A lot of these things can also contribute to heavy bleeding, but it's important to make sure that you're evaluating for that. Because believe it or not, there are many women with endometriosis that have normal, like, flow in their cycles, normal amount of time in their cycles. And that's more consistent with sort of classic endometriosis alone, rather than these other women that have heavy bleeding with their cycles. They usually have a concomitant diagnosis of both the endometriosis and the adenomyosis. And adenomyosis is diagnosed based on imaging. So in more advanced cases, sometimes you can see it on MRI. Sometimes it's missed. It's frequently missed when it's a little more subtle, or what you can identify at time of surgery. And like I was talking about, adenomyosis, the uterus is very soft. It's very sponge-like. It can be mottled in appearance, but you can see that texture difference at time of surgery. So this patient, going back, my patient with adenomyosis that had surgery for endometriosis. Now, this was not a endometriosis excision specialist, but she had surgery with her OBGYN, managed the endometriosis. It seemed, at least from what I looked, that most of the endometriosis was treated, but they did not talk to her about adenomyosis or the inflammation of the uterus. So while her pain was mostly focused on her period, that didn't change. And it was really frustrating for her because she didn't understand what the problem was. Like, was the endometriosis not treated? Well, sometimes it's not. It is imperative to make sure you're removing the endometriosis completely at time of surgery. But it's also important to make sure you're looking for other etiologies. Some people have IBS. Some people have Crohn's disease with their bowels. Some people have interstitial cystitis on their bladder. I always look inside the bladder on surgery to help evaluate for these other symptoms. And then some people also have adenomyosis. Adenomyosis is the most common concomitant diagnosis with endometriosis. If a patient has endometriosis, at least a 30 to 40% chance that they have adenomyosis. Now, if you see adenomyosis on imaging, like an MRI, or they've been diagnosed with adenomyosis, their risk of having endometriosis is almost 90%. Women with adenomyosis almost always have endometriosis, but what's funny is it's not always the flip side. And some of this is how it's diagnosed, which kind of skews some of those diagnoses. But this patient came into me and we started talking about options for treatment of adenomyosis. And even though she'd been offered different medications, but nobody really told her what these medications were for, how they were working, how they can help with the adenomyosis. Instead, she was just like, "Oh, stay on birth control pills or try birth control pills." But in her mind, they were using this to try to treat the endometriosis instead of the adenomyosis. And so it's very important, one, to take time to explain what's going on with your body, explain the different potential etiologies of the pain you're having. But also it's important to understand that not every patient or every person that we see in the practice wants to have the same outcome. It also depends on what your goals are. Are your goals, quality of life and, decrease pain? Are your goals fertility? Are your goals that you want to be as natural as possible? You don't want to take any, prescription medications. You want to look into a lifestyle changes. And all of these things are completely reasonable. Treatment for endometriosis is not a one size fits all. It is very much of a multidisciplinary approach. Um, Adenomyosis is treated usually with progesterones. It can also be treated with a hysterectomy. Hysterectomy does not treat endometriosis, for example. Endometriosis is treated with excision surgery and removing the endometriosis from these cells. Um, Adenomyosis and endometriosis both can also be treated with significant lifestyle changes, diet, exercise, physical therapy, acupuncture. All of these other areas can certainly decrease the systemic inflammation that your body is experiencing. And I have seen a few patients in my practice who have been able to manage almost all of their symptoms by very dramatic lifestyle changes. And it is hard. It is not easy. And even I have many patients who have done these lifestyle changes and still have, still ultimately have to have surgery or have to have other treatment plans. But it can be done, and it is important to understand all of your options. And it's also important to understand your resources. If this isn't working, what are the next steps? If we have surgery and I'm still having pain, what do we do after that? Or do I have adenomyosis? Have we talked about that? How important is it to treat the adenomyosis? Just kind of walking through all the different possibilities, after surgery, but it's imperative to understand what we find at time of surgery and that to be explained to you. I try to explain it to my patients even ahead of time, kind of in anticipation. These are the things that I'm looking for. I will tell you if I see these things or if I think that they're like a part of this diagnosis and if they should be incorporated into our multidisciplinary treatment plan. And so my patient with adenomyosis, decided that she was going to go with the physical therapy. She started strict diet changes, and she ultimately went on a low dose progesterone and saw a big difference, in the adenomyosis symptoms that she was experiencing. And she does desire pregnancy in the future, but she's going to stay on a low dose progesterone until she feels ready to start trying for pregnancy. Again, this is very much of a personal decision, but it's important for her to understand all of her options and to be able to have that autonomy to research, learn, and understand what's best for her body, because this is not a one size fits all. So the next thing I want to talk about is the red flags that they'll never tell you about. You're told, recovery after surgery takes time, but this too long, like how long is too long? What does too much pain feel like? Most women never really get an explanation for this. So one patient that I saw, had stabbing pain every time she stood up. Her doctor told her it was scar tissue. It wasn't. Her pelvic floor was in full spasm, something that was 100% treatable when somebody finally looked. You're not broken. You were ignored. If recovery feels wrong, there's a reason, and it's fixable. In my practice, I have a multidisciplinary holistic approach. This does include surgery. However, with that approach, we also talk about pelvic floor physical therapy, medications for muscle relaxation and spasms, diet changes, exercise, acupuncture. We do talk about medications. Medications are not wrong, but they're just not for everybody. But it's very important to understand all of your options. I do not push medications, but I do want you to know what your options are. There are medications that work for some patients and some patients they don't. Sometimes you have side effects and they don't work well for you, but it's important to understand all of your options. And then going forward, we talk about what are next steps. If you're still having pain, if this is still not working, what do we work with? Pelvic floor spasms after surgery are incredibly prevalent. Women have muscle pain, muscle spasms in their pelvic floor. Some of this is related to healing from surgery, but it shouldn't be prolonged. This should be, in the first week or two. If you're continuing to have it, then it's certainly reasonable to start working with other options for management. Getting into pelvic floor physical therapy, you can do that as soon as 2 weeks after surgery, starting working with pelvic floor physical therapy. Medications to help with pelvic floor spasms, rather an oral like muscle relaxant that can help you kind of decrease some of that tension. You can do vaginal suppositories, medications that are compounded vaginally that you place vaginally to help with those muscle spasms. And it's a dysfunction of the pelvic floor. Sometimes after surgery, it actually gets worse before it gets better. And so it's very important to understand what we're looking for. Adenomyosis, because of this chronic inflammation, certainly can affect the functionality of the pelvic floor. It can cause spasms, it can cause inflammation. Your nerves run in your muscles. So if your muscles of the pelvic floor are spasming, if they're tense, if they're dysfunctional, it certainly can contribute to the nerve pain that patients have as well. And so it is imperative to one, be aware of the different side effects and symptoms of adenomyosis and surgical management, kind of what to expect afterwards, but also to be able to give resources, whether it's pelvic floor physical therapy, diet plans, exercise. And I'm not perfect. I certainly don't know everything, but I do feel comfortable trying to give patients resources for next steps. And surgery is imperative for endometriosis, but it's also imperative to evaluate for that adenomyosis or other concomitant diseases with endometriosis. That way we are treating you as a whole, because if we're only treating one area of your pain without treating this in a multidisciplinary holistic approach, that's a lot of times when we don't get our best outcomes. Some of my patients even see a physiatrist. So a physiatrist is a doctor that kind of manages and specializes in nerve management of the pelvic floor. They can use muscle relaxants. They can use medications to help with that central sensitization of pain, or sort of how your body is responding to pain. They also can do nerve injections. Dr. Rusha Kapadia is one of my go-to. She's here in the DFW area. She does a lot of management of pelvic pain and down regulation of that central sensitization of pain. But this specific patient, there was a few things that we did kind of right off the bat. One is I got her an appointment with pelvic floor physical therapy. We started a mild muscle relaxant, and then I did have her see the physiatrist to kind of work on down regulating some of that central sensitization of pain, because it's all working together, and then it kind of crescendos for these huge pain responses. And so if you can work on all these different areas to try to down regulate some of the inflammation, usually that's when we get our best outcome. And so, it took her, 3 to 4 weeks to kind of get all of this treatment put together. And she's doing so well now, but you have to be able to identify what these symptoms are. The adenomyosis is contributing to this, as well as the surgical healing, but you shouldn't just keep watching it. At some point, you have to start, implementing intervention. And so trying to set my patients up so they have this multidisciplinary approach, so they understand what resources they have, what next steps are, what should we do after surgery, because surgery for endometriosis excision is very important, but it is imperative to identify the other etiologies of your symptoms, whether it's the bladder symptoms, bowel symptoms, adenomyosis, and then have a plan for it afterwards. But if we just go in and are a one-trick pony and only treat the endometriosis but don't look at anything else, we're missing something, and it's a disservice to patients long term. Lifestyle changes, physical therapy, medications, talking about all of your options so you can decide what's best for you. And some of it is a trial and error, trying certain things before you start to see a benefit. If that's not working, kind of going in a different direction. But it's important to know all the resources, and again, attack this inflammation, this pain syndrome for all angles, because that's when we're going to get our best outcomes. So I am going to pop over to the chat. Again, we are with Endometriosis Center of Excellence. I'm Dr. Rachel Haverland. I'm going to go through the chat and try to answer some of these questions for you. In the chat, there's also a link that has been put in there in order for patients that are here on the webinar to have a visit with me. So I want to clarify what this link is. So this link is a link to a calendar. At this calendar time that you specify, it will not be a meeting with me directly. It will be a meeting with my office manager. Her name is Cyrus. She answers all my phones. She will help you answer questions. And at that time, you'll meet with her, talk to her about surgery scheduling or visit scheduling. And if you do decide to schedule, you will then be put on my clinic schedule. But I just want to clarify. So this calendar that you're seeing in the link is a link to meet with my office manager. At that time, she'll go over your insurance. She'll go over like what's available to schedule a clinic visit with me, what that looks like, kind of anticipation of the visit, and if we talk about surgery and kind of what next steps are. But I would love to meet with you in person and go over your individualized plan for treatment, because endometriosis is very It's very complex. It is not a one size fits all. This is not an algorithm. Not everybody needs the same treatment plan. Not everybody has the same symptoms. And like I mentioned earlier today, not everyone has the same goals. So I'd love to meet with you and talk to you about endometriosis, especially if you think that you also have concomitant adenomyosis. What your options look like, what they are. So this link in this chat will be a calendar to meet with Cyrus. She's again my office manager who answers my phone, and she'll be able to talk to you about scheduling a visit. And then at that time, you'll be put on my clinic schedule. So I just wanted to clarify that this meeting that you're making is not a specific visit with me. You'll meet with my office manager first, and then get a time to meet with me. But kind of just going through. This person says, interesting. I always thought that the uterus was harder with adenomyosis. And that, yeah, you're right. There's some misconceptions, but the adenomyosis cells secrete fluid. And so the fluid kind of creates like little lakes in the muscle of the uterus. And so the uterus is very soft. It's very boggy. And if you cut open the uterus, like after a hysterectomy, for example, you can see the little lakes of fluid, and it makes the tissues very soft and friable, meaning the uterus is not as hard. It kind of tears easily. Some people have an adenoma, which looks like a fibroid. Those adenomas are very soft, whereas a fibroid is usually harder, more like a muscle, whereas adenomyosis is much more soft, which is interesting. This person asked, does adenomyosis affect the sciatic nerve? And that is very important. Adenomyosis does frequently radiate to the back and down your legs. So the uterus is heavy, and usually with adenomyosis, it's a little bit enlarged, it's heavier. And when it causes inflammation during your cycle, because that's when these cells tend to be secreted most commonly, it sits right there on your sacrum. So the sciatic nerve lives right underneath the sacrum. And so when this inflammation is putting pressure there right on the sacrum and the sacral nerve root, it actually absolutely stimulates sciatica, which is caused by the sacral nerve root. So many women with adenomyosis do feel sciatic pain or pain radiating to their back or down their legs or even into their butt related to their cycle. And so these are symptoms very frequently associated with adenomyosis. Caveat is you can have these symptoms with endometriosis as well. And so it does make it a little bit confusing, but especially if it's related to your cycles and related to heavy blood flow, frequently related to adenomyosis. Here's a question. If adenomyosis is causing infertility, is there anything that can be done, or is there nothing that can be done? So with adenomyosis. So endometriosis is the most common cause of unexplained infertility. It's very common. Up to 70% of women that are, within childbearing age, endometriosis is contributing to their unexplained infertility. Adenomyosis can affect implantation. So adenomyosis can make it harder for the egg and the sperm, once they're fertilized, to implant into the uterus, because the uterus does have some inflammation. Now, it is not as common as endometriosis, for example. My doctors and the fertility experts that I work with frequently can give you progesterone prior to trying. Like my patients with adenomyosis, if they're going through IVF, for example, they are given progesterone or some sort of hormone suppression prior to implantation to give them their best chance at suppressing some of those adenomyosis cells prior to implantation. And there actually is very good evidence that it's helping with implantation. So remember, hormones and suppression do not work very well for endometriosis, but the uterus actually does respond well to progesterones. The adenomyosis typically does respond well, or much better at least, than endometriosis. So working with a fertility doctor, sometimes they give you a few months of progesterone or medications to subdue some of the hormones to try to decrease some of that inflammation prior to trying. Or like I said, if you're going through a medicated cycle before doing transfer, a lot of my fertility doctors will give rather progesterone or Lupron or different types of medication before the transfer. Now, this is not Lupron before an egg retrieval, but before a transfer to try to suppress some of the uterus. This says, I'm going to answer one more and then I'll kind of go back to the lecture we're having. Do you treat endometriosis on women who've had a hysterectomy and BSO? I do. Unless the endometriosis was not treated initially at time of surgery, there's a high chance that there's endometriosis left behind. So, unfortunately, many women have been treated with a hysterectomy and removing the ovaries previously, but their doctor may have not removed all the endometriosis. Removing the uterus itself does not treat endometriosis. Now, it does treat adenomyosis. That is the good news. Adenomyosis is essentially cured with a hysterectomy. But it is imperative to make sure that you're removing all the endometriosis around the pelvis and around the abdomen, because if you leave that behind, you still have endometriosis. You may have treated the uterus, but frequently you still have endometriosis. So I do surgeries, unfortunately, on women that have had hysterectomies, especially if the endometriosis has not been properly treated. So we go in surgically, we look at the diaphragm, the liver, the gallbladder, the spleen, the stomach. I look at the small intestine. I look at the appendix. The appendix is a common place for endometriosis to spread. I look around the nerves. I look around the ligaments. I look at the ureters. Those are the tubes from the kidney to the bladder that carry urine. It's a very common place for endometriosis. I always look inside the bladder with a camera called a cystoscopy. I look at the bladder from the other side with laparoscopy. I look around the colon. I look at the nerves that innervate the colon. We look at the blood supply that was left behind. But number one step is to make sure all endometriosis is removed. And even women in surgical menopause, which is what is considered after you remove the ovaries, you can still have endometriosis. Menopause does not completely cure endometriosis. Now, many women, when they go through menopause, do see some improvement in their endometriosis symptoms because their estrogen levels are lower. However, endometriosis can technically make its own estrogen. It uses other hormones to transition into estrogen. Also, if a patient is taking hormone replacement therapy, like add back estrogen to help with some of their menopausal symptoms, then it gives, endometriosis, more significant time to grow, which is not wrong. There's certainly many benefits of hormone replacement therapy. But it's important as a first step to make sure that all endometriosis has been excised and removed from the pelvis. Then implementing these other treatment plans, whether it's medication, rather it's physical therapy, rather it's seeing physiatry, which is with Dr. Kapadia, rather it's, management of other symptoms, kind of depending on what they are. But it's imperative to make sure you're doing this in a holistic, multidisciplinary approach to get your best outcome. But unfortunately, at time of hysterectomy, if not all endometriosis is removed, you have a high likelihood of it recurring. And I see that, unfortunately, relatively frequently, probably once every few months. I operate on a patient that's had her uterus and ovaries out, and we find endometriosis that was left behind. And so removing that is the first step. And then next steps is letting your body heal and working on what's left, kind of reversing some of those long-term sequelae of that chronic inflammation. And this is very much of a marathon, not a sprint. Remember we talked about this at the very beginning. Surgery is not the finish line. It is certainly a first step, and it is imperative to fully evaluate all the symptoms and the other etiologies that can cause your pain. But afterwards, this is a marathon, implementing different different ways to downregulate the inflammation, improve the central sensitization of pain, the inflammation, rather it's treating IBS or celiac disease or, interstitial cystitis or working towards, treatment for the adenomyosis. But first step is making sure that all endometriosis has been thoroughly excised, but also evaluating for the other symptoms, especially related to the adenomyosis, because it is so common with endometriosis, and many women aren't told they have adenomyosis, or maybe their doctor didn't feel comfortable evaluating for adenomyosis, or just kind of left in the dark as to what some of their symptoms continue to be from. And so it's imperative to understand how this inflammation works and the different concomitant diagnoses associated with endometriosis, so that we can get our best outcome and treatment plan. So next, we're going to talk about what actually works. So most women leave surgery without a real plan. No one tells you how to calm inflammation, reset nerve pathways, support healing muscles, reduce hormonal triggers. You get a prescription and a handshake and you're done. And I try really hard to set you up for success. Real recovery happens with a coordinated plan. Physical therapy, diet changes, lifestyle support, inflammation control, and a strategy that matches your body. And some of this is referrals. Some of this is referrals to a hormone specialist or a physical therapist or a physiatrist like Dr. Kapadia that helps manage, nerve inflammation and the central sensitization of pain. For some women, it is hormone management, using medications that help with some of the inflammation from their uterus if they do have adenomyosis, or placement of an IUD during time of surgery. Other women, it is jumping right into fertility planning and working with their fertility doctor as to what next steps are as far as, goals for fertility and sort of what that looks like. But it is imperative that you have a coordinated plan and a strategy that matches your body and your needs. So one patient I had, this was a few months ago now. She started pelvic floor physical therapy and worked on, down regulating some of the inflammation. And within 8 weeks, her pain dropped by 70%. She did not need surgery again. She just needed a plan. And after surgery, she was feeling good for a little bit, and then she kind of dropped off. And she reached out to me. She's like, Doc, something happened. I was feeling really good after surgery, and then all of a sudden I'm feeling worse again. This does not mean your endometriosis has recurred. This just means we need to start making sure we're managing the other inflammatory symptoms. And again, this is a marathon, and we have to attack endometriosis and this inflammatory pathways from all angles so that we get our best outcomes. And it is a labor of love. Unfortunately, endometriosis is a lifelong disease. It is technically not curable. With that being said, I I do believe in an excision surgery and getting to the root cause and removing the cells, but also improving your quality of life and your pain. Just because technically you still have endometriosis does not mean that your quality of life has to be, debilitating, that you can't function the way that you want. You can't be with your family. You can't be with your significant other. You can't go to work. You can't go to social events. That should be treated. Even though you still technically will have endometriosis, it is imperative to manage the symptomatology of the endometriosis and improve the inflammation and ultimately improve your quality of life. So you don't need to suffer. You just need a strategy. So now hopefully you guys understand a little bit that surgery was not the finish line. Persistent pain is not your fault. And adenomyosis, the hidden twin, may be the missing piece that nobody checked for. But knowing why you're hurting isn't the same as knowing what to do next. So that's why I've created a way to help women get answers. We've been doing this, for a while. I want patients to get answers now, not months from now. I want to, put in a treatment plan. The first step is good excision surgery, but also evaluating for the bowel symptoms, the bladder symptoms, the adenomyosis. What other etiologies in addition to endometriosis are contributing to your symptoms? Then, hey, this is your plan. I've already given you diet, changes, given you physical therapy referrals. We've talked about acupuncture. If you need additional referrals down the road, physiatry, hormones, talking about all the different options for treatment so that you can decide what's best for you. I do feel very strongly in women's autonomy, making decisions for your body. Endometriosis is a complex disease. This is not a one size fits all, and it's not an algorithm. Different goals, different symptoms, different areas of endometriosis. Some women do have adenomyosis, some women don't. It is imperative to be thoroughly evaluated in order to come up with the best next steps. And so I'm going to go back to the chat for a little bit. Again, in the chat, there is a link to schedule a visit with me. So I just want to clarify that link in the chat is a calendar invite to meet with my office manager. Her name is Cyrus. She answers my phones. When you meet with her, she'll be able to go over your insurance. She'll be able to go over dates that are available to meet with me. And she'll kind of talk you through the scheduling process. And then at that point, you'll be able to get on my clinic schedule and have a face-to-face visit with me down the road. But I just want to clarify that calendar that you see there is not a visit with me directly. It's a visit with the office to make sure that we get you scheduled to meet with us down the road. But I would love to meet with you. Endometriosis, like I mentioned, is it is a complex disease. I mentioned this. The consultation with me, it should be a holistic approach. This does include surgery. My plan includes surgery and then a 6-month postoperative plan and implementing exercise, diet, physical therapy, acupuncture, talking about hormones, sometimes implementing, physiatry. But it's a private one-on-one call with my team. First, we review your symptoms. We talk about surgery, identifying what's likely contributing to keep you in pain, determine if adenomyosis is involved, and build a personalized step-by-step plan, to finally heal. This isn't just a 10-minute checkup. This is a visit. It's a strategic recovery session focused entirely on you. Like I mentioned, endometriosis is not a one size fits all. This is not an algorithm. Treatment should be very much managed individually. And I try to give my patients resources up front so they can start implementing them after surgery. But it does take a lot of time and it takes a lot of effort. But my patients that are willing, really to put in this time to decrease the inflammation, and treat their body and their endometriosis as a whole very frequently have better outcomes. So, here's the reality. We open a limited number of consults each month, and we can give women the attention, she deserves. Once those fill, the next spots are about, 8-10 weeks out, but we do have a few saved, from this webinar, so we can try to get you in more quickly. If you're still in pain, if you're still confused, if you're tired of being dismissed, click the link, book your consultation before these schedules fill. I would be honored to see you and talk to you about your journey. Again, first step is making sure that all endometriosis has been excised and removed surgically. Number 2, evaluating for other symptomatologies that could be contributing, including adenomyosis, the evil twin of endometriosis that is very common. And it is imperative, 1, to have a high suspicion for it, 2, diagnosis at time of surgery or with imaging, and then 3, give you your options for management, because again, it is not a one size fits all. So imagine waking up without pain, imagine moving without fear, imagine feeling like yourself again with a plan that you trust and a team who fully listens. This starts with one decision. Meeting with an endometriosis specialist or somebody that understands the symptomatology, the overall inflammation, and how endometriosis affects the body as a whole. So I'm looking forward to, we're building your recovery together and working together to treat the endometriosis, not just from a surgical standpoint, but as a holistic approach. And this is not easy. This is a marathon. But you're worth it. Your quality of life is worth it. And, women with endometriosis tend to miss social events. They don't move up at work as often because they're missing work, and people see them as, lazy because they're missing work, but that's not the case. It's because of their pain. And so trying to treat endometriosis as a whole, working on this, multidisciplinary approach to make sure that all areas of endometriosis are treated. Sometimes that includes surgery, like I said, is the first step, and but next steps are making sure that we're fully evaluating you, whether it's inflammation. Like I said, pelvic floor physical therapy is paramount. Diet changes, finding the foods that are causing you to bloat, causing more inflammation. Working, at least knowing what your hormone management options are. Hormones are not for everybody. Sometimes they're in the form of birth control or progesterones or an IUD. They are a good treatment for adenomyosis, but this is very much an individualized treatment plan. If you don't feel comfortable with hormones, I do not push those on you. You don't have to fail every hormone management before getting surgery or before, moving on to next steps. I just want to make sure that all options are given to you, because you certainly are affluent enough to make your own decisions for your body and your health. You know what's best for you. And I always say that to my patients: trust your instincts. You've been dealing with endometriosis for years, sometimes 5 years, sometimes 20 years, sometimes 30 years. And if something doesn't feel right, trust your instincts. If you feel like your endometriosis has recurred and you've done these anti-inflammatory treatments, you're probably right. Some endometriosis is more aggressive than others. If you feel like you have adenomyosis, you have a lot of the symptoms of adenomyosis. Well, you're probably right. I feel like I know a lot about endometriosis. I've studied it for years. It's my life's challenge and work is to try to give more education on endometriosis and to treat as many women as I can. My goal is to try to treat younger women so that they don't have to suffer for as long. Um, I know the statistics, I know the research, but you know your body. And if you're telling me that something doesn't feel right, if you're telling me that this isn't working for you or that's not a good option, you know. And I think that's very important to understand this individualized treatment plan. It is not a one size fits all. Adenomyosis is sometimes very confusing when it comes to endometriosis because it is the uterus itself. And we always talk about how hysterectomy does not treat endometriosis. That is true. It does, however, treat adenomyosis, and it is common to have both. So it depends on what your goals are. It depends on what you've tried. It depends on what you want for next steps, as to, how you want to live your life going forward. And that's different for everybody, especially based on your fertility and your age, or a lot of my patients have diseases that sometimes can increase their risks after surgery, like Ehlers-Danlos syndrome or mast cell deactivation. And so all these things are important to take into consideration when you're deciding what's best for you. And again, it is very much of not a one size fits all. So I'm going to go back to the chat just for a few minutes and, kind of, reset. So answer a few questions and then I'll go back to finishing up the lecture. But one patient asked if I have experience with removal of endometriosis on the colon or on the bowel. I absolutely do. About 30% of my patients have endometriosis on the colon. Sometimes you can cut it out. Sometimes you can shave it. Sometimes you have to put a suture in. And then every once in a while we have to call in a colorectal doctor or myself and we do what they call a bowel resection. So we take out a section of the colon and it just depends on how aggressive the endometriosis is and how much we find. But I do have a team of doctors, including colorectal surgeons and urologists. I have a cardiothoracic surgeon I work with. It is important to have a multidisciplinary approach also in the operating room to make sure that we do this correctly and safely. With that being said, I do about 300 cases a year. I feel very comfortable treating endometriosis surgically. I do a lot of my own bowel and bladder work, working on the ureters, but I have no problem calling in, other surgeons and specialists when needed because I just want to make sure it's done right. I want to make sure it's done safely, but also want to make sure it's done correctly. And so if we need to call in other surgeons, we absolutely will. So kind of going back to, adenomyosis and surgery, it's important, like I said, to calm the inflammation, reset the nerve pathways, support the healing muscles, and reduce, hormonal triggers. So now you understand surgery wasn't the finish line. Persistent pain isn't your fault. And the adenomyosis, that hidden twin, maybe the missing piece. So it's really important to evaluate for that. So I look forward to meeting with you and talking with you, at a visit, going over, a personalized plan. Again, in the chat, there is a link to meet for a calendar invite to meet with my office manager, Cyrus, to kind of talk about scheduling to visit with me. She'll go over your insurance, how scheduling works, and talk you through that process. So you'll be able to see that again in the link. But I just want to answer a few more questions because we have a few more minutes. So one person asked, are there specific symptoms to look out for that would indicate endometriosis has recurred? That's hard to know because everybody is a little bit different. If you're having symptoms similar to what you had before surgery, that may indicate that endometriosis has recurred, especially if you're already doing the anti-inflammatory treatment plan. Strict diet changes, decreasing your inflammation, from diet, acupuncture, pelvic floor physical therapy. If you're working on all of these areas and you've continued to do so, but you start to see some of your symptoms recur that you may have had previously, that certainly is a sign that may be a possibility. Sometimes, however, it's related to the adenomyosis or pelvic floor dysfunction. It can be nerve pain. And so at that point, it's reasonable to be evaluated to kind of figure out what next steps are. But if you feel like your endometriosis symptoms are recurring, unfortunately, you're probably right. There's certainly different types of endometriosis that are more aggressive than others, but it is important to listen to your body and kind of trust your instincts when it comes to that. But again, I appreciate you guys spending the last hour with me. I'm very passionate about endometriosis, and endometriosis affects so many women throughout the world and throughout the country. At least 1 in 9, 1 in 10 women have endometriosis. It can cause pain. It can affect your mood and depression. It can affect fertility. It can affect your daily functioning. It affects relationships. This is not a benign disease. It is a very real, overall, whole body inflammatory disease. And so we try to treat it that way to get our best outcomes. And I know it takes time, and I know it is not easy, giving you all these referrals and working with, a dietitian or working with physical therapy, but it's worth it. And you're worth it to get your best outcome. Your quality of life matters. And the longer you wait, the harder it is to reverse some of the long-term sequela that endometriosis can cause with that central sensitization of pain. So I appreciate you guys spending, the last hour with me learning a little bit more about adenomyosis and hopefully endometriosis. I look forward to hopefully seeing you in the clinic, or down the road. Some of my patients I actually see on here, so they've seen me before. Maybe you learned something today that I didn't talk about, in my visit with you. But I'm really looking forward to meeting with you and talking to you about your treatment plan. So y'all have a good rest of your Wednesday. Merry Christmas, Happy Holidays, all these fun things coming up. We will plan to see you next month for our next webinar. But like I said, y'all just try to enjoy your holidays the best you can, and I'm looking forward to meeting with you. Y'all have a good day. Bye bye.